All right, so which case should I start off with? Trying to remember. Oh, this one is not. It's an interesting case. Let's see here. So this is a. Let's see if did this come over here? Sorry, it's freezing. Oh shoot, it didn't come over. I'll save that one for later then. So, oh, here it is. I do have the CT. Okay, so here is it's a pretty classic case, but it's just a nice example of a woman who had an abnormal chest X-ray and was having some shortness of breath, and then came in with a quite a large, ugly, fatty mediastinal mass. Really not a diagnostic dilemma about what it is, but it's just a very nice example of a large, ugly mediastinal liposarcoma. I think we've shown a couple of these, and they biopsied it to confirm it was. We have a nice kind of PET showing uptake in it, and these really aren't that uncommon, and it's interesting because they're always, people don't think about them. They think they're really odd and strange. And I don't know what other people think, but I've seen I've only been doing this about 10 years, but plus residency. I mean, I think I've seen like 1 or 2 thymolipomas. And those are always considered to be, according to AFIP literature, like the second most common thymic mass and fat, the second most common, one of the more common fatty masses in the mediastinum. And I've seen many more liposarcomas than I have thymolipomas. Obviously they're different tumors, but it's interesting. I just have seen a fair amount of these, and not through the AFIP, just de novo. This case, which case was this? Oh, this was an interesting case only, and I'll show you this one. I like this one. So this was I was just reading a random X-ray, and I was just looking at the CT, and nothing, smoker, whatever. We're looking at the scarring and comparing it to the CT, and then we noticed, oh, there's a little piece of, you just assume that that's connected to the thyroid, that it's just going to be a little piece of thyroid. Now, the interesting thing is that there was also a non-contrast study, and if too lazy, but if I put them side by side, so here's that very, very hyper attenuating thing on the contrast enhanced study, and here's the thyroid, and on the non-contrast study, you can see this little focus is actually very hypoattenuating, which is a little weird for a thyroid. And so we looked up her history, and sure enough, she had a history of hypercalcemia, and this turned out to be why is my the fusion imaging not coming across? Well, anyways, if you can look below, I don't know if you guys can see it, just to save me having to figure out how to load this thing properly, you can see there was marked uptake on this MIBI scan, and that this was a parathyroid adenoma. So just very different enhancement pattern. I just thought that was a kind of a neat case where she also has a unrelated angiomyolipoma in the kidney, but just very hypoattenuating on the non-con, and it's one of those very, very vascular lesions. And I don't think anyone reasonably would call that and here it is on the contrast enhanced, anyone would reasonably call this a parathyroid adenoma on the CT. I think most people on the contrast enhanced would just say it's a little piece of thyroid extending back. But anyways, I thought that was cute.
What kind of a nuclear scan was that, Seth? It wasn't.
I said MIBI, but I think that's wrong. It's a
yeah.
It is a MIBI. It is a MIBI, right?
Just a MIBI?
Yeah.
I think so.
I think it's a SESTA-MIBI. I honestly, I have to check to see which one they did. I know you can do SESTA-MIBI scans for them, but I have to check exactly which one that it was done.
Cool.
I know in Maryland we used to do SESTA-MIBIs. And then what was this case? Oh, this was cool because again, it's something that I just haven't seen a lot of. And one of my co-faculty here picked this up and noticed that there's just this very weird, this person has a million other issues that are much more important. She's never had surgery, and she has this very strange just contour of the right ventricle where there's this big divot and it kind of comes in and then it goes out, and there's this pouching out of the portion of the right ventricle, the free wall, and then the left ventricle. And she pointed out to me that you don't really see any pericardium here. And, you know, that you can see it in certain places like over here, but you really have no perceivable pericardium. And then sure enough, we happen to have an old, let me pull up see which one is here is good. Happen to have an old MRI on this person. And you can sure enough see that, you know, here's pericardium and it just ends. So this is, and the other thing that's interesting is you expect, you know, I was always taught that you should really have space, a gap between on the chest CT, a gap between the where the aorta and pulmonary artery kind of meet in the region of the AP window, because the pericardium, you should have a defect there and you should see kind of air insinuating here. But here we have that upper portion of the pericardium here, so we're not getting that gap there. Does that make any sense?
Yeah.
So we have the superior aspect, but we don't have this inferior aspect. And I just never see, first of all, I've only seen like 3 or 4 cases of this, but I just thought that was a very nice explanation for why the heart is kind of pouching out like this just inferiorly, because we just have a very localized absence of the pericardium.
So how about coronary? You have
yeah, and you can kind of see how, like, look at this thing. It's just like it's being compressed here normally, and then the whole rest of it where it's not is just kind of shooting out very oddly. So let me see. You want a straight coronal?
Yeah.
So here's a straight coronal starting anteriorly, and then this is the portion that's outside, out here. And
yeah, that's really interesting. Really nice.
so I guess it's just a partial absence. And at first I thought she showed to me that had to be post-surgical, but sure enough, she hadn't had any. So here you can see nicely pericardium, and then out here, there's just nothing. Anyways,
Cool.
I thought that was cool. And then, this is the my first time I saw this, and I think I showed this around to some people because I just hadn't seen this before, but it's one of the things where it had to be what it was. So this is a woman who had a lung cancer that was invading across the major fissure, and for some reason, again, I just moved here. I don't know the specific practices of certain people here, but they took out the right upper lobe and right lower lobe and left the right middle lobe in the patient. And the patient underwent a CT a couple of days before this, and it was a non-contrast study, and it looked very similar. It actually looks worse now, but there was this, you have this right middle lobe here. It's extraordinarily edematous, and the pattern of it is not, I don't know, I looked at this and I said, this just looks like, even on the pre-contrast, you know, venous obstruction pattern. You just got this marked septal thickening, this consolidation. And the other thing that was really weird for me, because we didn't have the contrast study at the time, was the pattern of the arteries, or the smaller arteries and the smaller bronchi. You know, normally you expect a lobe where the arteries and vessels are going to course towards the hilum, and these actually course like anteriorly, and they aren't going towards the hilum. You know, the hilum should be obviously back here. They're going anteriorly with that, and kind of have a parallel approach to the anterior chest, or straight perpendicular. And then here you can see on the contrast that they kind of come out here and take this very strange U-turn approach. And then the other thing was that the pulmonary vein, the one that was left, is this beak shape. So I called up the surgeon, and after this, because we said, I said a couple days before this patient has torsion on the non-con, and they're like, no, she's fine, she's doing great, it's not torsion. And then she kept kind of, her WBCs were going up, she was kind of having more difficulty, a little more pain, but they're like, oh, she's fine. And then finally they got the contrast, and I said, listen, it's torsed, I don't know what to tell you. They're like, oh, she's doing fine. And so they waited actually another 3 or 4 days after this study to take her to surgery. And they said that the right middle lobe they didn't use the word torse. They said had an atypical position and was very edematous, and it filled up, was bigger than the liver and filled up the whole right chest because it was basically no way for venous blood to get, or for the thing to drain. So they did a completion pneumonectomy. So it is, you know, pretty much a case of torsion. But the interesting thing is that I get your guys' opinion on this. So they did a pneumonectomy on this poor woman. They did a pneumonectomy on her, and she was having, you know, basically the pneumonectomy bed is not filling up, and there is presumably what looks like potentially a bronchial leak here at the margin. It's hard to tell. We don't exactly see it, but we can see bronchial stump, and then this little air collection here. But the other question I have for people is that, you know, they did a completion pneumonectomy. They left the pleural space in. This is some hemorrhage and air in the pneumonectomy bed. But where do people, does this look like, where do people think air is here? Does that look like normal pleural space, or I was debating whether or not this air down here was in the pleural space or not. I mean, I don't know where else it would be besides the pleural space, because I was wondering if it could theoretically be dissecting in the extrapleural soft tissues, but it's just a very strange look.
It looks pleural because if you go down towards the hemidiaphragm, you've got a layer of some kind of liquid on both sides of it that look like pleura.
Yeah, it's just a weird log.
It's all irregular because it wasn't a clean pneumonectomy. It was all an inflamed, angry space.
So you think it's okay, inflamed? Okay, that makes more sense.
Go back in there, and who knows what that torse lobe did in there, and how much blood and yuck was in there. And I wonder if it's just a complicated pneumonectomy space.
Okay, it was just very odd to see this.
Yeah, I agree.
Loculated airflow election here, and then you have this down here, and I was just saying I've never, you know, sometimes with bad pneumos and stuff, we see air dissecting with the leak. We see air dissecting into the extrapleural soft tissues, and you get a weird appearance. But it was just too big, and I had not seen it that big before. And the other thing one of my colleagues showed to me was that you can see here that there's, you know, thickening of the pleura here. So it's got to be in the pleural space, but it just had a weird look.
What do you guys think the white stuff is sitting in there?
The white stuff?
Just there's, in the basal chest, there's stuff. There's something there. What are those white things?
I don't know. I'm guessing it's fluid between loculations in the pleural space. That was the. You're talking about this stuff in here?
They didn't leave surgical material or packing or something in there. Should be empty.
Not to my knowledge. Again, who knows? But there's no mention of it. They just talked about the stump and the intercostal flap being intact. But
if you go to the windows like that and mag it up, and you go where the clips are, by the way, can you see any remnants of airways that go directly to the space, that there might be a communication between?
Well, that's what. Well, so
that space. Are there gaps broken?
So you're talking about from the bronchial stump to this?
Yeah, you were scrolling up and down. I thought I saw maybe a couple places where there may be connections between airways and that's.
Yeah, we were wondering if there was some sort of, I mean, because technically there shouldn't be any airways left, but we were wondering if there was a communication between the stump and this collect here.
Well, it's hard to say.
No, I don't know. We were actually going through this in short, very close detail and trying to see if we could definitively say there was a leak or not, because they bronched the patient and said there wasn't a leak. But I don't know what's better, the seats, because here you can see the suture and then the air next to it. I don't know what you guys think. I would imagine CT is probably, in my mind, probably a little better than bronchoscopy, but I don't know if there's actual maneuvers they can do in bronchoscopy to determine if there's a subtle leak or not versus just anatomic evaluation. But
well, there's enough stuff in that there that it's very puzzling to me. I don't understand this at all.
yeah, but this was the same person with the torsion. She had just a mess of a pleural space. So I think maybe, you know, I think Jeff's probably right. It just probably was a very ugly, infected, inflamed space. Because you can see even here before, actually, you know what, you're right. Because even before they took it out, this pleural space was getting really ugly from the prior lobectomies before they did the completion pneumonectomy. So that's probably, there's probably just loculation sitting in there.
It's probably fibrosis.
Exactly. And then as they took out the rest of the lung, those loculated spaces just got bigger to expand and take up this space. Anyways, a nice case of torsion, which I've actually never seen a case.
Or if not torsion, at least at a minimum, maybe that vein was occluded and you have venous ischemia.
Oh yeah, no,
and
yeah. They said the vein was, yeah. They said the vein was gone. They said the vein was completely out, pinched off. I just had trouble explaining, and you know, this course of the vasculature. And again, they said that I don't want to send the report, but they said it basically flipped over and was in a abnormal location. So I don't know what that means. They said it had moved into a posterior location and had a, so who knows?
Yes.
All right.
That's it.
Thanks, Seth. All righty. Who would like to go next?
I can show a couple.
All righty.
So we'll start with a radiograph. So I saw this as part of a national screening program. And I was concerned about the differential lucency here on one side compared to the other, and the high axillary fold on the same side that has the lucency as opposed to this more normal looking fold over here. So I thought this might be Poland syndrome. So I waited for a few years, and it turns out that this person got a screening CT scan. A CT scan is part of this screening program, and here's the CT from that era, and it indeed confirms that the absence of pectoral muscle on the left, the side of lucency. So we have pec major and pec minor on the other side, and we have no hint of those on the affected side. So this was indeed Poland syndrome here, or absence of the muscle. So I tried to do 3D and see if looking at the chest wall on a 3D skin reconstruction would show this. And you know, knowing what to look for, I could make it out, but it wasn't actually very impressive. So the clinical maneuver that helps bring this out is to have the patient sit, face you, and then put the elbows out and the hands on the knees, and then push down, and that will tense the pectoral muscle tendon going from chest to arm and help bring out the defect. So couldn't do that from the CT scan here. Unfortunately, you can't move the patient around and have them do maneuvers like that. But this is Poland syndrome, confirmed after 2 years. And this person has this mediastinal mass here following heart surgery. This was coronary bypass surgery. And you can see the mass in this location here. You can tell from the trail of clips, it looks like a trail of ants, that they did internal mammary bypass. And this turns out to be a aneurysm of a vein graft. So here's the vein graft sewn onto the aorta here anteriorly, heading along the west of the mediastinum here, and then entering this big graft aneurysm here. So saphenous vein graft aneurysm, full of thrombus, presumably. Okay, and the vessel seems to still be patent pretty far down. So this mediastinal mass was a graft aneurysm, venous graft aneurysm. And then this person presented with some shoulder pain, a whole bunch of x-rays of the shoulder and stuff like that, or I should say radiographs of the shoulder, and has this big opacity here. This person has bad habits, including intravenous drug abuse, and on a couple of years earlier had been suspected of having tuberculosis because there was apical consolidation on the left. And so I think that history was available, and people saw this abnormality and then went to CT, and it turns out that this is not a lung lesion, but is this fluid collection here with some gas bubbles in it. And there's a component that seems to extend under the pectoral muscle here. So we have a theme today of pectoral abnormalities. And this was interpreted, and there's some pleural effusion down here, small amount, and this was interpreted as empyema, pleural empyema, with extension into the chest wall. So empyema necessitans, it's going to rupture through the skin and stuff like that. But I think that the main abnormality here is not pleural, it's really chest wall, and I think that's brought out nicely on the sagittal reconstructions here. You can really see that this fluid collection here with the gas bubbles is centered around the first costal manubrial joint, and that this is really centered in the chest wall, and the pleural effusion is really minor. So this is not primarily a pleural, but instead is a chest wall problem. And the man is actively injecting drugs. He uses heroin. So this is really a chest wall abscess, and there's some, it's centered on this joint. Let's bring it back, cross sections. This joint is a favorite location for these blood-borne organisms to settle out. And the gas bubbles here probably are some of the gas that's normally in the joint, but redistributed because of the infection. If you look on the other side, you can see it's pretty common to actually have some gas in the in these articulations with the manubrium, either from the clavicle or from the first rib. So you often get joint gas in those things. I think it's probably from some distraction of the joint and nitrogen bubbling out of the bloodstream there. So I'll bet you that some of that gas was present and then just got redistributed by the infection here in the matrix here of all this effusion. And this lesion was surgically drained from outside. It resolved, and they cultured MRSA out of it, so it was methicillin-resistant Staphylococcus aureus, as you'd expect from IVDA. So
you think it's probably blood-borne and a form of septic arthritis that then extended and involved the contiguous tissues?
Yes, that's what I think is the process. Now, the person's right-handed, and it's, by the way, you can see the effect it's having here on the subclavian vein. It's narrowing the vein, but I think it's really being squeezed from the outside. There was some concern that there might be septic thrombosis in this vein. So since the person's right-handed, if you'd been injecting the left arm, you could argue maybe the organisms came up the subclavian vein and then got into the tissue around it. So you could imagine that it might come from this vein, but I don't think that's the usual explanation. And I've seen this location so common in IBD. I think when people inject other sites, I don't think it's local injection that's doing it bloodborne. What do you guys think?
Yeah, I would think maybe bloodborne started as a septic joint and then just spread from there.
Yep. And I just wonder, just putting it together, I just wonder if the fact that these joints like to get these little gas collections on, it's a normal finding on CT. I'm sure you've seen it. Yep. When I first recognized it, I was alarmed by it, and then I realized, wait a minute, I see this all the time. That I think maybe the same mechanism of creating a little vacuum in the joint and having stuff come out through the wall of the vessel, maybe that encourages organisms to come out in the same location. So maybe it's a mechanical effect that sort of sucks organisms out of the bloodstream. But I just made that up on the spur of the moment here because I've got nothing better to do. Okay, so this was a chest wall abscess centered on in a common location here. And this was a case that one of our former residents left with me. This woman had some shortness of breath. It's a young woman. She's from Austin, Texas, and she'd been traveling in Mexico. And she has this big, smooth lesion here, which is shown to be in left lower lobe here on lateral view, and it has arrows on it. And here's what it looks like on the couple of CT scans that I have. It seems to be a low attenuation, very homogeneous, watery fluid sort of matrix, and shown here again. And this has echinococcus organisms in it. So this was Echinococcus probably from a trip to Mexico.
Oh. You have to be associating with livestock, sheep or something?
Sheep, or something like that, right? Maybe she visited a farm or something. I don't have detailed history. And this person has what looks at first blush like interstitial lung disease, and you realize it's such an aggressive interstitial lung disease that it actually extends into soft tissues. You can see the interstitial lung disease here in the shoulder, soft tissues. And if we look back a day before, it wasn't there in the lung, but it was affecting the shoulders already. And on lateral view, the lungs look fine up there, and this is just hair. And I think there might be some styling mousse mixed in with the hair to give it a little extra opacity, a little more body there and a little more visibility. But I've seen, this is the second case I've seen of what looks like upper lung interstitial lung disease, or infection, sarcoid versus infection, with soft tissue involvement indicating it's really all just an artifact.
David, it's a classic case of trichothorax necessitatis.
There we go. All right, thank you.
Yeah, it's interesting. I have a ton of hair artifact cases I've saved. I have ponytails mimicking nodules. I've got braids mimicking micronodules. Sometimes it's helpful when you're thinking sarcoid, especially if you have hair braids or something.
Right.
Yeah.
Okay, cool. All righty. I see Brent and Howard are online.
I can show, I'll show just 2 or 3. I've got a bunch, but I can just show 2 or 3 if you like. Okay, let me make that go away. Let's start with this one. The finding here relates to the subcutaneous emphysema. I tried to get information about the context in which this occurred, and I couldn't really satisfy myself that I could figure it out, but it's not blunt chest trauma, and the notes were not detailed enough, but I wondered whether there was something about surgery or intubation at some point, or misposition of a tube, malposition of a tube or something, but I'm afraid I couldn't get that. But suffice it to say that if the finding pneumomediastinum and subcutaneous, and that's pretty obvious, what does it mean and where does it come from? So let me just show you that some supporting evidence for the Macklin phenomenon first of all. So I'm going to make this a bit big, but I want you to see, and I hope I can bring it out, that there are black lightning bolts of septal emphysema in the lung apices right there. And it's a very nice example of that. So you see a bunch of black septal lines. And then there's at least one place here where I thought there might be subvisceral pleural interstitial emphysema related to a pleural surface. And there was one other place that I thought that I could track air in the peribronchovascular sheath out into the lung. But I was pretty confident, having made those observations, that the etiology related to the Macklin phenomenon and nothing else like esophageal injury, for example. But another question that came up was, well, the person made the good observation, said there seems to be air in the upper abdomen. And if you're positing the Macklin phenomenon and so on, don't you worry about a pathologic process in the upper abdomen just by virtue of there seemingly there's air up here in the upper abdomen? So let me bring up what I think the explanation is here. First, I think the air in the upper abdomen is anterior pneumoretroperitoneum, not pneumoperitoneum. And here we're going to go way back to 1978, right? And there was this really nice paper from these guys talking about an anterior pathway for transdiaphragmatic extension of pneumomediastinum. There's no CT here, there's some images on pediatric patients, but they basically postulate that here near the costal and sternal attachments of diaphragm anteriorly is a pathway by which air can go from mediastinum to anterior pneumoretroperitoneum in the upper abdomen. And I think that this case exemplifies that. I think we may see a pathway by which air goes there. like right there. So I wasn't that disturbed by that because I think this pathway is involved. So I don't know if I've not seen this before, not thought about it too much, if I've ever seen cases like this. But I still think this is all benign area in the sense that this is not an abdominal problem, and it's the Macklin phenomenon. Somehow, somewhere in the intubation or ventilation, there was alveolar overdistension and then the Macklin phenomenon as an explanation for all the findings. Anyone have any thoughts about why that might not be the case?
No, I think it's
putting it all together.
A good story. And if you look at the gas in the upper abdomen, it looks like gas in the soft tissues where you get strands of other tissues as opposed to when you're in a space. Yeah, right there.
Yes. Yeah, right.
You can see the fat. So it's probably, yeah, that makes sense.
So I think it's that kind of putting it all together and making up a story.
So and I think we've all seen pneumo mediastinum extend downward into retroperitoneum posteriorly.
Yes,
around
hiatus aorta, yeah. But I forgot about this anterior pathway, and something jogged my memory, and I found that article that I was thinking about it. All right, let me show you this one. I'm going to show this entirely out of order, but let me just put these two together. So it's kind of a complicated case, but by way of background, this is a patient that has metastatic colon cancer. She had, on the left side, an intractable bronchosvascular fistula from tumor that necessitated ultimately a pneumonectomy, so left pneumonectomy. So here we have a patient at time X. You can see we still have skin staples. And then some days later, now we have a patient in which we have a lot more fluid in that post-pneumonectomy space. And you see that the heart has shifted a little bit to the other side. Just a little bit of air remains. Now, to go out of order here for a moment, I'm just going to show you kind of an interesting thing in the upper abdomen. So I obviously wasn't reading this, but I was looking for some interesting findings, having seen something else. So here is kidney. And I don't know if you can perceive on your screen, but there's an interface here that's convex downward between something right here and adjacent, less attenuating soft tissues. So here's an interface right there. So I'll leave that up on the left-hand side and show you the explanation for that. So of course what we have here is that interface produced by this. And this is tremendous inversion of that left hemidiaphragm. So it's way down. This is all fluid in the chest, not in the upper abdomen, where the diaphragm is inverted. So it's attached where the crura is, but it shows a dramatic inversion of that diaphragm. That indicates a huge amount of fluid there. So I thought that's really interesting anatomy. You know, the usual teaching is if you start in the abdomen somewhere like here, if you see fluid internal to the diaphragm, that separates out intraperitoneal fluid, which is this, from pleural fluid, except when you have inversion of the diaphragm, as you do here. But then the fluid internal to it is pleural space. So I think it's maybe one of the most dramatic inversion of the diaphragm that I've seen, with a tremendous amount of fluid projecting inferiorly.
It looks as if the ribs are being spread on that side too.
Ah, yeah, maybe. See, they're separated here, right?
Yeah.
Perhaps, yeah. I think you're right. So there's tremendous volume. Huh? And yeah, not sure why I did this, exactly what's going on, but unfortunately for this person, when they went back in and doing a VATS procedure to drain this fluid in part, they found what they described as a studying of tumor on pleural surfaces, as well as pericardium, because she's also got a pericardial fluid. So just a very dramatic amount of pleural fluid with inversion of the diaphragm. Pretty dramatic case of that. I'll just show one more. This is kind of a cute case. So if we start off with chest X-ray, looks like this, It's a bedside radiograph, but there's an opacity here. And this is what it looks like on CT. I wish I had thin cuts, but I don't. But this is what we have on CT. So we have a focal opacity, peripheral, right upper lobe. Perhaps in its periphery, a little bit about there, there's actually seemingly an undisturbed bronchus going through it, and it's got slightly lobulated margins. So let me show you on PET that we have FDG avid lesion in the lung. And we also have small but FDG avid regional lymph nodes as well, as you see right there. So of course people worry about lung cancer, but this is a relatively young person who shouldn't have lung cancer. And they did some biopsies, but the interesting thing about the biopsy result was not so much what was in the lung, which is not surprising, necrotizing granulomatous, but they actually saw cocci in the nodes from mediastinoscopy. So this is primary coccidioidomycosis with organisms in paratracheal nodes. So I thought that was really interesting, that they actually saw the nodes, in the organisms in the nodes rather than in the lung. David, you like that?
I love it.
Okay. All right, those are my cases.
Okay, thank you. Let's see, I will show a few if we have time, if anybody else. All right, let's start with this one. This is a young guy, I think he's in his 30s, and he flies, he's not a pilot, but I think he travels a lot, probably a consultant or something for a living, and has developed pneumothorax. And you can see here, and this was treated and had a hard time resolving. So they did a CT scan a couple months later to look for structural lung disease because his concern about going flying again. And we got very excited when we saw this. Let me change, there we go. You all see a CT, right?
Yep.
Okay. So you can see, let me make it a little bit bigger. Oops, there we go. You can see he's got, as we go down, we'll see more and more thin-walled cysts, but notice this one here. It's sort of a biconvex lens along the fissure. And then further down, we see some other thin-walled cysts along the veins and pleural surface. There's a big one down here. More and more in the lower lungs. Very perivenous, also along the pleural surface. But they're not round. Here they're actually along the septal pleural junction, running perpendicular to the pleura. So any thoughts, guys? I mean, we know what this is, but I'm curious.
Yep. Yeah, it's very distinctive. Got to be BHD, yeah.
Yeah, Bird-Hogg-Dubé syndrome. No, he has no skin, so there was a little bit of surprise. So the consulting service, we sent him back. No skin lesions. He has no kidney lesions, but only after thinking about it for some time, he did recall that his grandmother had some kind of kidney mass. So there is a genetic test that's pending on this, but we couldn't come up with anything else. I mean, this is so classic for Bird-Hogg-Dubé. But primarily manifesting only as lung cysts, and unfortunately for him, I think flying is probably not a great idea, given that any of these could rupture at any time. He's at high risk. And it's interesting, of all the cystic lung diseases, if you look at the literature, they always report 20% or so spontaneous pneumothorax. But in my experience, this is the only one I've ever seen actually do it consistently with a fair number of patients developing pneumothorax. Whereas I haven't seen that many with Langerhans cell histiocytosis, only a few with LAM. And I think it's because of the location of the cyst that so many of them are subpleural, whether it be along the fissure or at the septal pleural junction. So,
yeah, I think you're right. We see that, yeah.
Now you guys will all like this case because it's a usual Caney special. So this
Wait, I missed. I'm sorry. You said I was out. That was Bird-Hogg-Dubé?
That's the presumption. We're waiting on genetic confirmation.
Oh, okay.
It's a slam dunk from a standpoint. So this is a young woman who has presented with chest pain, has an area of consolidation on her radiograph. She's had multiple pulmonary embolism. So this is a subsequent one here. And this is a later CT, but it shows a nice area of infarct down in the middle lobe, a big effusion. But that's not why I'm showing this case. What I found interesting, of course, is her vasculature. So if we look at the left atrium, you'll notice there's a large single vein coming in. You don't see a superior vein. So if we follow her anatomy on the left, we'll see there's this vein running lateral to the lower lobe pulmonary artery that then dives underneath and connects. So it's a meandering vein, single vein. But what was even more cool is this other vessel that seems to be draining into the left atrium that runs superiorly, just medial to the left pulmonary artery under the aortic arch, and then dips out or moves out laterally and looks like a superior intercostal, and ultimately is connected to the left brachiocephalic vein. So this looks like a vessel draining a systemic vein that actually drains into the left atrium. So it has a...
Oh, really?
Yeah. So the meandering vein is of no consequence, but this is presumably systemic vein. Now, I don't know which way the contrast is flowing. My guess is it's probably flowing north, because I would say argue the left atrial pressure is greater than the left brachiocephalic vein pressure. But it was trying to be a persistent left SVC, I think, out here, and then somehow connected up to whatever embryonic pathway this was, and unfortunately landed in the wrong place. So I thought that was cool.
And the right pulmonary veins are okay, except there are two of them.
Yeah, two of them. The middle lobe connects to the superior, and the lower is all by itself. Now, she doesn't have the associated airway anomaly. I already looked. So we don't have any funny airways, but two vascular anomalies, probably somewhat related. This is a patient who has a known history of tuberculosis and presented with hemoptysis. Let me show you an old CT. So this is 2010 and has this thin wall cavity, left upper lobe, a little bit of scar around it. Looks like leftovers from TB, but comes back about 7 years later with hemoptysis, and now we see liquid layering in the cavity. There's consolidations around it, so it looks like an upstairs downstairs lesion. So obviously we would be very suspicious for reactivation tuberculosis. But what's kind of cool in this case is when we look at that, yes, there's nodules there, and there's also this funny ground glass around it. And then further down, we see this liquid layering in there. And when I change the windows, you'll notice it's pretty dense. And so if we continue on, you'll see right here is a little ball of contrast that seems to connect up to this vessel running along the wall that comes off this pulmonary artery right here. So left upper lobe anterior pulmonary artery. So a little Rasmussen aneurysm, or I guess appropriately pseudoaneurysm, inside this cavity. So presumably this is some blood in here. And then there's been endobronchial spread of blood and probably organisms as well.
My word, that's impressive.
Yeah. So I guess technically it's a Rasmussen pseudoaneurysm, since it's a mycotic type aneurysm.
Fascinating.
I'll show this one only because I have the pathology for it. I don't think it's that challenging of a case, but it's an earlier manifestation of this. So this is an old case that we were sent pathology for consultation on. So this is a young woman, smoker. You can see the emphysema. And she's got these irregular nodules kind of scattered throughout, and then you can see these irregular cysts. And so, I mean, this is no challenge to the more experienced folks up watching this right now, but quite a few cysts. And then as we go down, the profusion dramatically diminishes and really nothing to speak of at the lung basis. So a classic case of Langerhans cell histiocytosis. Now, this was about 3 years ago done somewhere else. I mean, we typically would never biopsy a case like this, but my kind pathologist called me just for a consult because he said it was so classic and he didn't have access to the CT. But so in exchange, I got these beautiful photomicrographs, and you can see, so this is the low power, and you can actually see these nodules, and you can make out a few cysts too. And then on the background of normal lung parenchyma, then we go, this is a high power image here. And this is a Langerhans cell here. They have these grooved nuclei, and this is in one of the lesions. You also see their eosinophils, which I always have a hard time finding because I'm colorblind, but there's one there, there's one there. And then, so when these are active lesions, you'll see the Langerhans cells, and here's the CD1A stain, which is a membrane stain. So all these are Langerhans cells staining positives for CD1A, so very specific. But with time, the Langerhans cells go away, and you can be left with this stellate-looking scar. You can see this sort of irregular shape of some of these. And what happens is the reason they often have these fuzzy margins is the inflammation sort of creeps into the adjacent alveoli. I wish I had a higher power image to show it. But they creep into the adjacent alveoli, expand the alveolar walls at those locations. And you can imagine when you're CTing that leads to these sort of fuzzy margins around it, as opposed to an impacted bronchiole, which would give you a nice sharp tree and bud nodule. But it's just nice to have the pathology on this, but most of the time we would recognize this as pretty straightforward. Okay. Anybody like to show some additional cases? We've got about 10 minutes.
Yeah, I can show if no one else wants to. One that is a companion to one of yours, if you want, or someone else. No one else wants to go?
I have some too. I don't know if there's.
Okay.
Do you want to show yours quickly, Howard, and then we'll let Brent go?
I'll let Brent go. That's fine. I can always show it afterwards or another time. That's fine.
Okay.
Okay. See if I can make sure I'm showing the right screen. Okay, so these are some cases that actually Arthur Stillman saw on just in a couple days' time that I think are really amazing cases that he showed me. So this is a patient, young patient with cystic fibrosis, and you can see that there's upper lobe predominant bronchiectasis, bronchial wall thickening, and mucoid impaction here. And this patient came in with hemoptysis, and one of the things that obviously we look for is any site of active extravasation that would suggest a target for embolization. You can see that the bronchial arteries here are very enlarged here, very hypertrophied, enlarged bilaterally, very juicy. And as you're scrolling down here, we hardly ever see any sort of arterial blush on these studies, but this is a case in which you can see down here that there's actually a little blush of contrast that is not within a vessel here. It's to the right of a pulmonary artery here, and it's adjacent to the bronchus, but this is a little blush of contrast that presumably is a site of bleeding for this patient, and they presumably are going to do an angio on this patient to embolize that. Checked today, and they had not yet done that, but I just thought it was interesting that we hardly ever see this, and a little focus of contrast blush there that would suggest a site for targeting for bleeding there. So I'm just curious how I presume that everyone kind of does these studies for hemoptysis and CF patients, but how many times have people seen actually active extravasation? I have to say that the number of times I've seen it have been very low number.
Very low, maybe one, if I can remember correctly.
Yeah.
Extremely rare.
Anyway, I thought that was worth showing. Here's this is a really interesting one that I've seen in a couple different sites within our system. This patient had an MI. Let me make sure I'm showing the right screen here. An MI about a week before a study was done at Grady, and the study that was done at Grady showed the following findings. Showed really hypoperfusing septum, really thinned septum and apex of the LV. And at Grady, we had the following finding, which is a connection between the RV apex and the LV apex. And so there was an ischemic ventricular septal defect that we could see, and you could see that fairly large ischemic VSD there. What we didn't have, what this patient was transferred to Emory with, is the additional finding here of this rupture of the apex of the right ventricle. So not only did this kind of rupture through the septum, and now this defect is, you have to trust me on this because I don't have the other study loaded, but it was smaller at Grady, and then within just a few days' time had become much larger ischemic VSD plus an area of rupture there from the RV apex. So just thought that was a dramatic example of a ischemic, post-MI VSD with an additional area of rupture. So you can see that they're, have a lot of edema, pleural effusions now. So presumably they were planning on doing maybe a percutaneous repair of the VSD, but it was much smaller back then, just a few days prior to this, and now there's rupture.
So is it from the RV apex for sure? Oh, yeah, maybe.
Well, yeah, it looks.
Oh, okay.
Looks like it. I mean,
Do you think it's filling with contrast and more opacified than the RV chamber because of the contrast going through the defect and then opacifying it, or something like that?
Yes, I think so. And it's kind of hanging out there because this area is not squeezing, and but I think this is all LV contrast that's come out and then gone into this area of rupture, and then it kind of fades out into the RV here. But this. I'll bring the other one at some point, but this is much larger than we had on the prior, so it had progressed just pretty rapidly. And it's in keeping with the literature, where literature says that left untreated, these things will, have a high rate of progression and poor prognosis. So, these have to be treated pretty rapidly. And we've seen obviously penetrating trauma cause VSDs, blunt trauma due to necrosis cause VSDs, and also these post-MI ischemic VSDs. So it's a good example of that.
It's a large VSD, right?
It's a large VSD at this point, and it was causing significant shunting. And then here's another case that Arthur Stillman showed me. This is a coronary case where the interesting thing here is that we're looking at the left coronary sinus here. Nothing comes off. And now looking at the right sinus here, there's a single coronary artery. And look at the course of the left here. The left comes and takes a low septal course here. So it's a septal course of the left coronary. And then you notice that the artery comes up, and then you're going to have, if you try to find the true LAD, should run in the interventricular groove there. So let's follow that up, and you can see that there's it's actually this vessel, and this vessel takes a very long, deep myocardial bridging course through the LV, and then look how it pops out there, and now it's in the interventricular groove. So this is a very interesting case. On any number of these things would be interesting in themselves. The single coronary artery, the septal course of the left main, and then also this deep bridge that's going on with the vessel that's really the true LAD. So I mean, the deeper the bridge, and the longer the bridge, the more symptoms can be caused. And I'm actually not sure if this patient was having some acute symptoms or not, but certainly dramatic anatomic findings here. So
at the origin of that left coronary artery, it's not running in the wall of the aorta per se.
No, let's go back to that. So here it's coming off, and then here it comes down. So you can tell it's not an intramural course. It's not following the course of the wall, and then it's really low compared to where the actual pulmonic valve is right up here. So this is much lower than an interarterial course would be, and you can see it's running along the septum. So by definition, a septal course here. So I'm getting off this vessel. That's the true LAD.
So there's, Frank, can you hear me?
Yeah.
So we had an interesting case the other day of so septals are benign, even with the bridge usually, but we had a case the other day of a guy with HCM and a single coronary with a septal course like this, and he was developing significant chest pain. So, it's interesting because the one group of people that get in trouble with bridges most of the time, or HCM guys. So, but it was very similar to your case, very long, very deep bridge through a very hypertrophied myocardium. So it'll be interesting. We're going to send him for a stress test to see if it's significant. But we just had a case like this the other day.
What's ATM?
What?
What's ATM?
He had hypertrophic cardiomyopathy. HCM, sorry. So he had very bad hypertrophic cardiomyopathy involving the septal, the septal segments, and had this very similar single course with the septal branch. And usually septals or whatever, I don't really worry about them because they're just nice benign courses, but he was having chest pain, and that's, the septals with the HCM can get in trouble. So it was just interesting. I'm curious to see what his stress test shows.
Yeah, I'll look into that. That's interesting. That makes sense that the more, they sort of compress the septal course, that normally you don't have to worry about this, but a lot more tick on that. Wow.
Yeah, because they fill during diastole, so usually it's not a problem. But but it'll be interesting to see what that one shows. But that's a beautiful case. And sometimes that can be also associated with the LAD coming around prepulmonic and supplying the distal portion. But that's a very nice, just single left septal left main. It's very pretty.
Yeah, great. I will give you a follow-up on that. And then one last coronary. Just want to show, because this is so, any one of these cases would be very, nice and rare, but here's another one. So this is a 33-year-old patient, female, who, during pregnancy.
Oh, nice dissection. Look at that.
Had dissection, and you can see that she's already been bypassed, has a couple different bypasses here. And you can see that at a site of the prior dissection, there's actually this area where, we can call this a pseudoaneurysm. There's, bulging outward of the left main there, and you can see the site of the prior dissection. And this is actually, a little pseudoaneurysm at the site of the prior coronary section. We don't get many of these referred to coronary CTA, and to see this, it's very interesting. And then also to see the little bulge there, that's the, pseudoaneurysm. I thought that was a very nice case.
That's great, dude. Is her LV? How's her LV look? Did she blow out her LV? Yeah, a little bit. Not too bad.
No.
The apex is a little out there.
Yeah.
But not too bad.
Yeah. But anyway, those are some cases I had this week. So.
All right.
Many of them.
Nice. Cool.
Dr. Stillman.
All right, guys. Well,
Great. Thank you. Great.
Talk to you next week.
Thank you.
Bye, everyone.